maps. Well, that's the way things are today. But we can't start if people can't get in. You're in. All right. Okay, I am informed that we don't have any technical glitches, so so anyone who is on the commission who is trying to get online should be able to do so. So I am going to call the meeting to order. Hello, Indiana. Here we are with our July meeting for the Commission on Aging. Rather warm day, but one would expect that in July. So here we are. And I'm going to do, the first thing I'm going to do is introduce Tom Pearson, who is the new, well, I don't want to get your title wrong, so I'll ask you, Tom, to introduce yourself from the Indiana Housing and Community Development Agency.
Thank you, Dr. My name is Tom Pearson, Executive Director of CDA, so Chief Ownership Officer for the agency as well.
Chief
Ownership Officer oversees the programs for family assistance and business and leadership.
Okay, well, thank you so much. This is a position that the legislature last year, I believe it was, put on to the Commission on Aging. We're very happy to have you because we know there's housing issues in Indiana for older adults. Okay, let's do a roll call. First of all, Becky Onspach. Becky, are you on? Robert Bischoff. I'm here. James Gone. Deb Lambert is here. Jennifer Lance. Steve McCaffrey. I know he had to be at another meeting this morning. Dan Mustard. I know he is not available this morning. Judith, you are here. Tom is here. Margaret Smith. Megan Springer. And Kelly, you are here. So 1, 2, 3, 4, 5. We do not have a quorum. So we will defer approval of the minutes, but does anyone have any adjustments to the minutes? You had a few, were able to review them. If not, we will simply file them and bring them forward for approval at the next meeting. We only have the May minutes filed, so we're doing pretty well this right now. So, but it is exciting to see 5 of us here in person. So, as well as our guests in the room. I don't know, maybe that's why I shouldn't call you that. Our folks in the room, let me say that. That's a little better maybe. But we have people here. We can have a discussion face to face, and online's fine too. So, but anyway, nice to have you in person. Okay, well, we cannot do elections. Any of you here, we do need a vice chair of programs, and what we're doing right now is Aaron and I somewhat talk about presentations, but we do like to have someone who is a vice chair who can make some suggestions and help with presentations throughout the year. I also know that with our advisory committee reports, sometimes the advisory committees want to do presentations. So be thinking about that if you're an advisory committee. All right, the next part of our agenda is a presentation this morning. Our presentation is on community health workers, and I think, Lisa, you're going to make the introduction. Yeah. All right, Lisa, I may not say your last name correctly, so if you will help me so I say it correctly, that would be
It is difficult to pronounce, but it's Lisa Schneekloth, and I'm the CEO of Sokoa Aging and In-Home Solutions. And today we're going to have my Director of our Community Health Worker Programs do a presentation on this fabulous, impactful program. And so I'll introduce Mackenzie Reed, have her come up and walk us through it.
Thank you. Welcome, Mackenzie.
Good morning. Thank you for having me. Pardon my absence. Okay, so as Lisa mentioned, my name is Mackenzie Reed. I'm our Director of Community Health Programs at Sokoa Aging and In-Home Solutions. So that is the area agency on aging that serves Central Indiana, so Marion and the counties that touch it. And we are here to talk about community health workers today. So does somebody have slides that they can advance for me, or do you need me to click it? Oh. Perfect. I have no idea where that came from, but sounds good. That sounds good. All right. So if you are not familiar with community health workers, community health worker, kind of the general definition, is that they are frontline public health workers that help individuals of marginalized communities access the health and services that they need by acting as a liaison and someone that comes from their community. So we are very excited to have community health workers because the magic that they really bring is that they are from the same communities, they look like, speak like, are deeply connected to the communities that they serve. And this really helps to break down a lot of barriers that individuals face when accessing healthcare, community systems, any of those things. So the whole goal is kind of that if I trust Sokoa and you trust me, then you can trust Sokoa. And so you will see community health workers at a lot of different locations, primarily usually embedded in health systems. But we are really excited that we have had community health workers since April of 2022. I was actually our first community health worker hired at that time. And at the time, we had them just helping with care transitions for individuals that we already served. So they were embedded on case management teams and worked with individuals when they came home from the hospital or nursing facility for about 90 days, strictly over the phone. A lot of screen and refer, a lot of information sharing and just mentorship at that point. And so we did that for about 2 years, saw really great outcomes even before we really figured out what we were doing. And so we were able to enter into a partnership with Impact Care in June of last year to help us kind of standardize some of those practices. Impact Care is one of the leading national evidence-based community health worker interventions. And so we are really excited to partner with them to help, like I said, kind of give some legs and some standardization to what it is that we were already doing. And so I think whoever has my slides can go to the next one. Okay, perfect. So what the actual community health workers provide. And a lot of these things that you see here, like goal setting, advocacy, things like that, that is pretty standard for all of our social services, right? But the magic behind CHWs is that they do this with them, not just telling them where they need to go. And so our new intervention, which we'll talk a little bit more about in a second, includes face-to-face visits. And we say that this intervention is longer than options counseling, shorter than long-term case management. So it's for about 90 days. And the goal is to be able to connect them to clinical, social, community care so that we can hopefully prevent or delay them from needing our long-term services. So in the process of this, adding in the impact model and kind of really looking at what we have here, we also expanded this to serve not just Sokoa clients, so not just those that are older adults and people of any age with a disability, but also those that we call pre-Sokoa. So those are folks that have maybe chronic disease, social determinants of health risk factors, maybe lost a primary caregiver, have had a recent fall, things like that. To be able to get to them sooner and find them where they are so that they will need us much later, if at all, to help them to age in place as long as possible. Because we know that in the health systems that exist, the community systems that exist, if we never meet them, if they never come to our front door until they are already in need of long-term services, it's almost too late at that point for us to really make a difference. So a couple of examples, sorry, to the slide gods, you can go back. Thank you. So a couple of examples of what our actual community health workers have done. We have lots of CHWs that have been able to get people into permanent housing that were unhoused before that. So that's one of our big things that we work towards. We also help someone get a new ID and insurance card to be able to set up a primary care visit, and transportation to get to that visit, to be able to get new durable medical equipment that they needed. A lot of our community health workers will go grocery shopping with individuals to help them understand reading labels and understanding what things to get for new diets and things like that. And so we have one particular individual that was able to try hummus for the first time. Her client was on her new diabetic diet as a healthy fat. We talk a lot about the hummus because it was a very exciting experience for her. And then we also have, a lot of this system navigation that we get to do with them. So we had one individual that was in a wheelchair, living on the 3rd floor of a building, new diagnosis of cancer, elevators out in the building, apartment complex refusing to fix it. Community health worker called everyone in the city to find a way to fix it. Couldn't, so was able to get the fire department to come take her down, get her to her appointment, and then bring her back up when she was there. So we really walk alongside them to help solve those problems creatively in a way that most of the other programs that we offer don't have the capacity to do. So, okay, now we can go to the next one. Perfect. Okay, so this is what our actual intervention looks like. Again, this is modeled after the Impact Care model. And so we do weekly in-person visits for up to 90 days. Again, short-term intense stabilization, with a focus on linking them to clinical and community supports. So addressing some of those SDOH needs, getting them connected to primary care if they're not already, helping them to set up things in place to do preventative care so that way they stay healthier longer. And then one of the really exciting things that we've started doing this year is adding in community partners that we are partnered with and stationed at to also meet people organically in the community where they're already congregating. So this is like our congregate meal sites. We also have partnerships with some local YMCAs, the library, a homeless shelter, to be able to meet people where they're already going to be so that we can catch them sooner. Right here. Okay. So the next one that I want to share and kind of the most exciting part is the data and why we believe this works, why we've invested into this. So you can go ahead. Perfect. So this data on the slide is from our first 2 years of the program. So like I mentioned before, we really had any standardization when we were really just kind of seeing what we were doing. And so we expect these numbers to be even greater now that we have a much more streamlined model. We've just only been doing that for a couple of months. So but biggest things I want to draw your attention to is the huge over 30% increase in folks who understand their medications. So one of the things that we believe to be really important with this model is partnering with other organizations that can help us do the work. So one of those is the Purdue School of Pharmacy, and we have pharmacy students overseen by a pharmacist that can do medication reconciliation for patients to help them understand their medications better. So we give a lot of credit to that as well alongside the CHW for that metric, because we really talk about medication since we know that that impacts a lot of other conditions that they may have. And then an increase in folks feeling more stable with their mental health, an increase in those that feel confident in continuing to stay at home and receive services, and a decrease in those without access to food. The biggest one, though, there at the bottom is up to a 64% decrease in hospital visits. So we looked at the number of hospital visits before CHW intervention and the number after, and that's where we get that number from. We also partnered with Purdue in their Center for Health Excellence, Quality, and Innovation to be able to do an ROI assessment for the program. It's harder for us to kind of put financial outcomes tied to this since we don't have the hospital data. But from what we've invested in the program, Checky was able to find that for every 10 cents invested per client daily, which is the average cost per client, there was an average absolute reduction of 0.775 emergency admissions and 0.306 inpatient admissions per client. So definitely statistically significant there, definitely decreasing that. And that really underscores the value of the program and how inexpensive it is to implement, but how great the impact can be afterwards. So,
Mackenzie, I'm sorry if you said this and I
nope,
missed.
you're good. Go
But
ahead.
what's the N on these surveys? So how many people
Yes.
were surveyed or responded?
Yep. We worked with I believe this was over 2,000 individual clients over about 6,000 visits, is what we're looking at. I can absolutely pull that up and give it to you as well. Yeah.
So you've served as many as 2,000 people with
Yes.
the,
Yeah,
okay,
and that was within the first 2 years, so it's more now.
that's amazing.
Any other questions? That's all that I have prepared for you today. So
Finance.
yes. Yep, great question. And part of the exciting part, I know Lisa was able to share a little bit the last time of like, how do we make this sustainable? That's definitely a big topic. So we have been able to lean into grant funds, obviously, as most of us do, to start up some of these things. But we are now utilizing Medicaid fee for service. There is a CHW code under traditional Medicaid, so we're able to bill for those with traditional Medicaid for this service. That is new within the last couple of months that we have started doing that, and we are one of, if not the first in the state to do that. The code has been around for quite a while, but nobody really uses it. And then we are able to also submit to Title III-B under Older Americans Act for evidence or non-evidence-based health promotion. We were able to get a direct service waiver for that. So
Awesome.
Do you have a waiting list of people that want those services, or do you have a cap on people, or?
we do not. So it's up to capacity of our community health workers. So our CHWs can serve up to about 20 people at a time since it is so intensive. And so we don't currently, but we do get internal referrals and external referrals. Just a huge growth opportunity. If we have more people, we'll hire more people to serve them. So
So how many are you currently? So
we have 9 community health workers that each have a caseload of about 15 to 20 that rolls. So yeah.
awesome.
Thanks.
Are there other AAAs doing this?
There are other AAAs that have community health workers that I know of. I am not sure exactly what that intervention looks like. I think we, at least from my understanding, have the most robust program of this with our partnership. It really helps to be able to do that with Impact. But I believe the others have them. I just don't know what their exact model looks like.
That's fair.
Yeah.
So where do the folks, where do you get your referrals from?
Yeah, great question. So anyone internally that meets any of our eligibility criteria, so that is had a recent hospitalization, a fall, chronic illness, social determinants of health factor, really anybody that we see can qualify. So our internal staff refer them. We also receive information from the Indiana Health Information Exchange when folks go to the hospital, and we get alerts for our clients that do that. So we outreach to them. And then with those community partners, we have about a dozen community partners that we are either on site to see their individuals, or they send us referrals for people that we can help. Thanks.
Tom, I'm looking across at you. As she was talking, we have a number of people who have housing issues.
Yeah.
And I'm wondering if there's any communication exchange going on between IHCDA and what you're doing.
Go ahead if you. No, and yeah, you would be right. We are really kind of scratching the surface because we know that there's a lot of need in that. So we have not made a great connection yet. So I would love to, because it is a huge thing that our CHW has helped
I
with.
think that'd be a great idea.
Yeah, I mean, that's part of what we're doing here and why we thought we need somebody on housing on this commission, because we hope that we're exchanging information and get some synergy out of some of this. Because folks are really, really, really struggling and they don't know where to go. And there are some really tough, if you don't have a place to live, and it's like the person you talked about having difficulties where they are. It's an issue, so absolutely hope we get a little communication, see what might happen. Community health workers are an exciting new, because they're not new, but for Indiana, it's new, put it that way. Possibility for us. You're gonna hear me all the time and just tell me you're tired of hearing it, but with policy devolution moving from federal and state to local levels, we have to sit down, scratch our head, and there's no infrastructure at the local level, and try to figure out what we can begin to do locally, working with state and federal entities to try to support what's going on at the local level. And it's hard. People in primary care get people in there, they don't know what to do because somebody is decompensated their health and they can't manage anymore where they are, but they don't, you know, with some community supports could stay in the community rather than institutional care and all this craziness. The worst place we can send people is back to an emergency. That's expensive and there's not staff available there.
Right.
I mean, they're there to deal with hemorrhages and people that can't breathe and whatever else, not with social determinants of health issues and understaffed there. So we kind of got to find some new solutions here to some of these things.
And we're even starting to look at kind of that preventative. So if you never make it through the front door of a hospital, if you never make it through the front door of Socoa, how are you going to know? By the time you do, it might be too late for us to make a difference. So that's kind of one of our huge initiatives with putting people in the community, is to get them before, you know, a lot of people have distrust of health systems for very valid reasons, that we want to help to alleviate that so that they get more preventative care up in the hospital list.
Well, maybe some of the people out in some of the housing for older people can get more aware of some of these issues and it would be more of a preventive issue if you're seeing someone that's struggling. So hope there's good communication between you and IHCDA. Thank you.
Could we get a copy of your slides?
Sure.
Awesome.
Sounds good.
You just said that it brought up a question that you use the Indiana Health Exchange, which is fantastic. So when you look at that 64% decrease in hospital visits, is that validated through? the Health
That's where we
Exchange?
get that information
That's where it's from.
Yes,
So it's not self-reported. It's
Nope.
not.
it is hospital admissions
It's actual
from,
admissions.
yeah, the health.
That's amazing.
Yep.
That's amazing.
Funny map. That's it.
Well, no, I mean, I just think it's, yeah.
It's different though. The data matters different.
Yeah.
Sure.
Yeah.
Yep. So that's a good point though. The top data that you see, the 4 at the top, those are all self-reported that we do on like a pre and post test. But the hospital visits is based on looking at those IHRA
That's
reports.
really remarkable.
So this is coming through. Let's get this, be sure this was in our minutes. There's a 64% decrease in hospital visits. And this is, your statistics are coming through
The Indiana Health.
Indiana Health Information Exchange.
that in minutes. please.
And your funding comes from?
Yeah, so a variety of different places. So that we have some grant funding that will help to support it. And then that Medicaid reimbursement that we do for fee for service. For those under 60, we're currently just able to do that for fee for service. And then Title III-B, or non-evidence-based health promotion. A combination of all of those. We are also walking out, being able to utilize the Medicare funding that exists now for the Community Health Integration Code. It's just a little bit trickier as a community-based organization because of the required referral and oversight from a provider more than Medicaid. But that's something that we're walking out with Impact as well, to talk through what options might be available for us there as well. So, yeah.
Well, one thing that's very exciting that I'm hearing is that with what you just were talking about, we're starting to bring the area agencies on aging more on board as partners in health and well-being in communities. Because that's really important, and we know that it's evidence-based, we know it's there, it just hasn't been done, and it's costing us a fortune of what we're doing, running to just the health system. We have to work together here to make this work.
Yeah.
And our issues in this country, you can cut funding for programs, but it hasn't diminished the need.
Right.
It's just moved the issues down to the local level where there's no infrastructure to deal with it. So it's a new day for us to find some solutions. The reason we got the state and federal programs was because the local government and communities didn't have all the resources they needed to take care of people. So we had to move mid 1800s. We went to the state. Into the 1900s, we went to some federal programs, and now we rolled it back to about 1800, where we were with our policies with the local government. But here's the problem with older people. Let me try to. I am an old person. Okay, if anybody gets confused here or insulted. Older adults. we're got more of us living longer than ever before, and we have healthcare possibilities that we didn't have in 1800. So if you, and I'm not trying to be political, this is just facts. So, you know, it's very expensive to get the healthcare. You know, you can't get a knee replacement, a hip replacement, go in and get stents put in your heart. We didn't have any of that. So when you don't have funding for some of this and it's all personal risk, financial risk, that I don't know how many of us could make what, one hospital visit for a surgery and we'd be out of luck after that. So I mean, we just gotta come down, roll up our sleeves and figure out what we're gonna do. You have to think about it differently. And that's where I sort of am. And so the community health worker is helping greatly when you can see that kind of results from it. And it's validated. It's not like this is just, you know, that was pointed out well today. So we need to just take stock of this and see what we can do with it. So anyway, it's exciting. Thank you so much.
Thank you. Thank you for having me.
You have a really wonderful program. Congratulations.
Thank you. Thank you.
Well done, Mackenzie.
Thank you.
Okay. Now we have a job to do. Erin. One of the things that the Commission on Aging does is act in an advisory capacity to the Division of Aging, and part of that responsibility is to review the area plans that the area agencies on aging have put forward to us. So
I only printed 4 copies because
Someone's gonna have this one, because I printed mine.
you printed your, okay.
We haven't had this many in person. Big optimist.
thank you.
Before I jump into the area plan, I wanted to first thank Mackenzie and Socoa for presenting on the community health workers. And I also wanted to just mention with the passage of House of Bill Act 1391 related to the choice program, it expands the focus of the choice program to really look more at prevention of not only institutionalization, but also hospitalization. So this model is one that we could potentially replicate or expand through choice funds as well. And with 1391 being focused more on a Medicaid diversion, I think it all fits. Nice. Thanks. Okay. The area plans on aging. Every 2 years, the AAAs submit an area plan on aging to the Division of Aging. It's a requirement of the Federal Older Americans Act related to maintaining the designation as an area agency on aging. In the plan, the AAAs project their future activities, goals, objectives, their planning processes for how they're going to approach services for older adults and caregivers in their communities, as well as providing information on, and Stephanie, you can go to the next slide, assurances and provisions related to compliance with the Older Americans Act. And we also include choice and other grant-funded programs in the area plans as well. And there's also information in the plan about coordination and advocacy efforts in their planning and service areas. Their current area plans are approved for federal fiscal years 2022 through 2025, and they expire in September. And so these new plans will go into effect October 1st for a 2-year cycle. The current plans are on a 4-year cycle because we did a sort of a shortened process as we were coming out of COVID and moving into some of the changes in long-term services and supports across the state. So just to give an overview of the timeline and the process that we followed, in February, we released the area plan guidance for the current cycle. We held a series of technical assistance webinars. One was a general overview. We did a more intensive review of greatest social and economic need requirements related to the Older Americans Act and the new federal regulations pertaining to targeting of resources. We did one on finance, various waivers that are part of the area plan process, and then just kind of general wrap up and open questions. The area plans were due to the state at the end of May. We have since then been very busy going through an intensive review process, and I want to thank my team that are here for all of the efforts related to that process. Each plan has been reviewed by a minimum of 2 people, and then some of the sections, including the finance sections, we've pulled in other subject matter experts and follow a standard process. In reviewing the plans, we are bringing observations and information on the process to you today. We will continue working between now and the plan start with the AAAs on any needed revisions, clarifications. We've already sent out a first round of questions and requested updates. The plan is to have the review process and approvals completed before the start of the federal fiscal year, and then the plan will go into effect October 1st. Next slide. There is a lot of information included in the area plan, and I have listed everything here. I'm not going to go over everything, but essentially it includes all of the requirements that are in the Older Americans Act and Code of Federal Regulations that we have to touch on through this area plan process, as well as some narratives and projections related to the services that are going to be provided. What are your goals? What are your strategies, et cetera? So it is a massive packet of information, and we very much appreciate that the AAAs put a lot of effort and time into this process. There is a requirement in the process that they obtain public feedback on their plans. They're supposed to be available for public comment for a minimum of 30 days. And how they met that requirement, all of that is part of what they explain to us in their area plan. And the area plan really mimics the state plan process that we go through every 4 years at the state level, whereas our state plan obviously reflects the state. The area plans are specific to their designated service areas. So ACL outlines the key topic areas that are supposed to be reflected in the plans. And for this current upcoming state plan cycle, as well as this area plan cycle, there's a focus on Older Americans Act core programs, greatest social and economic need, expanding access to home and community-based services, and caregiving. And for the most part, these are kind of the broad topic areas that our current state plan and past area plans have focused on as well. Each of the AAAs, and we have 15 different area agencies on aging serving 16 different planning and service areas. So we received a total of 16 plans because there needs to be a plan for each planning and service area. So each AAA proposed objectives and strategies related to these broad goals that were consistent across the network. The first one is ensure consistent quality and timely information and access to long-term services and supports. And this is kind of getting at their role as the Aging and Disability Resource Centers. We tried to ensure that there was alignment between the goals and directions in the area plans as it relates to the state plan on aging, as it ties into the multi-sector plan on aging, and also the dementia strategic plan. You know, we have these requirements for a plan for this and a plan for that. We just want to make sure that we're not creating these plans in silos and that there's alignment and the bigger picture that we're all working towards the same goal. Might look a little different or just be a piece of it, but we just want to make sure there's alignment. So we really spent a lot of time trying to make sure that that alignment was there. So goal number 2 relates to strengthening and expanding Older Americans Act core programs, ensuring high quality, efficient, and effective home and community-based programs and services. This aligns obviously with the key topic area of the Older Americans Act core programs, greatest social and economic need and caregiving. There are a couple state plan goals related to improving health, well-being, and equity, and optimizing physical, emotional, and financial well-being. The next goal, protect and enhance the rights and prevent abuse, neglect, and exploitation of older Hoosiers. This relates to the Older Americans Act core program of the Ombudsman program. We use both Title III-B and Title VII funding to support the long-term care ombudsman. And this actually mirrors very much the state plan goal. So as the Commission on Aging, and Dr. Burke alluded to this earlier, you have a role in the study and discussion of problems of, as it's worded in the statute, the aging and the aged, not my favorite.
That's really awful language.
It is. That's, yes. And so historically, we have reviewed the area plans with you as a way of bringing you into the planning process and also having a opportunity to ask any questions, et cetera. So if there is any kind, I mean, we don't have a quorum, obviously, but if there is any discussion or motion or approval, if anyone has any contractual business or directorship role with the AAA, you'll need to recuse.
Recuse.
Like recluse is not the right word. Recuse yourself. Okay. Any questions before I get into the highlights of the plans? And I'm not going to read everything for all 16 of the plans. We just really wanted to kind of share some highlights from the plan. So for each of the 16 areas, we've listed which counties are in the planning and service area and the maps up here. We've listed who the executive director or CEO of the area agency is. If there were any applications for the provision of direct services, we listed those. We have federal and state statute that says if a AAA wants to provide a service directly, they have to request a waiver from the state. And there are 3 different reasons that a direct service waiver may be approved. It's if there are no providers in the area or a lack of provider capacity, if it's part of the administrative responsibilities of the AAA, or if the AAA has demonstrated that they can provide the service at a higher quality or more cost effective. So there's an application process for each service that the AAAs are requesting to provide directly. There are some services like information and assistance, case management, and outreach that are exempt from the direct service waiver process. And then we just picked out some items of note or highlights, whether they were plan strengths, particular goals that jumped out at us, or any reviewer comments or observations. So the first area, planning and service area 1. Oh, next slide. I jumped ahead.
Erin, can I ask a quick question? I apologize, and it may not be quick, so I apologize for that as well.
Okay.
Going back to goal 1, ensuring consistent quality and timely information and access to long-term services and supports. This may be a question for Hannah or one of the AAA CEOs, Lisa or Jenny here. how has, given the area agency's role change in managing waiver services for the over 60 population, I have to assume that some of the revenues that you generated in that case, by delivering case management services were used to support aging and disability resource centers and staffing and otherwise, and that may be a false statement. So if it is, then I'll stop my question, but I'm just wondering how the diminished role the AAA plays in case management for the over 60 population has impacted you financially to be able to support the volume of inbound calls that you receive.
Could you come up to the microphone?
If it's that, I'm just asking the question because it's the first goal listed, right? And it's an important
It's a
one that you'd
very
be
important question.
able to manage.
Yeah, I mean, it's greatly impacted our reserves and our ability to support the ongoing services. So I think we're just, adjusting and looking for other ways to make up that loss of revenue. So I don't really think I want to get into the nitty-gritty right now, but yes, it has greatly impacted us.
And that's consistent across all of the AAAs.
I think this is what you're asking, and I can tell you this, in the last 18 months, I have lost between 65 and 70 staff because of all this.
Out of,
180 altogether, and we do transportation and stuff, and we have, a tenth of the state. So I can tell you, yeah, it's been big.
So you lost about a 30%.
Mhm.
And so ultimately now you are having to look to different means of funding to supplant what was once a steady revenue stream for your organization to continue to expand services.
Yes.
Thank you.
That needs to be duly noted by the commission.
Yeah, but you're not serving as many people either. Not happy with this.
Actually, they still have the same responsibility to manage the inbound calls to support access to other community-based services, including the pathways waiver. So that responsibility hasn't changed.
That wrongs the pathways, and they just push them on to Marcus, that's us.
Well, and
Well, that needs to be responded to, I think, because that was one of the questions that I had too with the way we're doing things now. And I think that just started here the 1st of July, but people are still calling. It's still going through the AAAs, but they lost funding to deal with the inbound call volume. The call volume doesn't decrease. Now you're saying, well, they wouldn't
No.
have to spend time dealing with things, but you still have to talk to the person and find out what's going on in order to, if you're really going to spend time. It's not just a matter of, people don't even know what they're asking for most of the time. I think when they call, Judy,
So if they're
that
over
takes
60,
time.
can't you just say, automatically say you can call 211 and they can give you the information?
That is why we wanted to pause on this, so we duly note what's going on. I don't even think people would know to call, they don't know who to call. We've got people, they don't know whether to call 211, they don't know what the area agencies are. All of a sudden, we've shut down any word about pathways. I don't think people even know it exists because we can't talk about it anymore. There's no marketing outreach.
So my question on that is, I know that this commission gets feedback from the folks at Pathways of how that program's going. And our title is Commission on Aging. Is anybody checking with the people who get these services to see if the services as they are now are better, equal to, or worse than? Because to me, that's the end of the day issue, right? So is this new program providing better services than what we had before? It's a bit of a rhetorical question, but
Well, that's more of a DDARS OMPP question that I'm sure we're not.
Yeah, and there's.
Right, I'm not
Positioning
equipped,
it.
but I mean, I know
There's
that
an
there's
evaluation,
quality and
but,
evaluation.
Somebody in the state should be checking on this. in
Right.
my opinion.
There is an evaluation.
Yeah, and there's a whole quality team and
Yeah,
Um,
that's checking with the people getting the services versus the vendor providing the service. Is that, because that's my question.
okay, and I can't
I
answer
know
that,
they're
but I can
talking-
bring it
I
back
know
to
they're
the.
talking to the vendors,
Mhm.
right?
All right, you know what?
I know they're talking to the MCEs. Are they talking to the people that are getting the service?
That,
That's
let's
my-
ask her an update on that at the September.
I will
meeting.
ask.
Okay.
It's a very good question, the evaluation process for the Pathways
Okay.
program.
And I did want to address the ADRC, in particular, the ADRC contract. So we have historically contracted with the AAAs for what we call waiver intake activities, the options counseling, initial service plan development, Medicaid application assistance. With the shift to Maximus as the level of care assessment representative, we still have a contract with the AAAs to support some of the pre-waiver or waiver intake activities. And we've redesigned the contract. Before, it was very kind of task pay point oriented, you know, you do this, we'll pay you this unit rate. So we still have some of that in the contract related to initial service plan development that they're still, the AAAs or the ADRCs are still doing for the health and wellness, traumatic brain injury, and fee-for-service pathways waivers. But for Medicaid application assistance and some work that they're doing with the waiver waiting list support and what we are calling kind of no wrong door long-term services and supports, we have monthly flat rates that each of the AAAs are receiving to kind of support those activities, with the idea that somebody calls, if it's a call that has to go to Maximus or they need to be referred to the MCEs, they have some support for that. So the individual is not, the idea is the individual is not just going to be told, well, just call this number, but the AAAs will kind of help them navigate the process.
That's
Well,
what I want to make sure, like, there still has to be some type of funding and support.
Yes,
For them to own that responsibility,
Yes.
because the calls don't decrease
right.
just
And
because of this change.
historically, we have funded the ADRC contract at, it was 7.5 million. We have had some additional funding with the HCBS ARPA funds for the last couple of years. With the cuts in choice with the budget bill, I believe the contracts are 7.125 million across the network. So it's about a 10% decrease just because we lost Medicaid match.
How much, what percentage did the of loss to the ADRCs did the AAAs get? How much was cut? I mean, right, well,
And so they're
I know they lost, they lost some funding due to the change over to Maximus, but I mean, how much was cut? What percentage of what went to the ADRs? I don't know, maybe I'm not saying that correctly, somebody help me here, but
So
we're
historically,
kinda
we've
talking-
used 3.75 million of choice and we got a 50% match on it. So we lost 10% or 5% of the choice funds, which made us lose 5% of the Medicaid. So it's essentially a 10% decrease
and
from normal, not including the extra funds that are gone.
And to Judy's point, it kind of sounded like, well, this is all switching over to Maximus, so everything, all the calls will go there, and the AAAs have lost their funding for some of these things because they're no longer doing it. But 211, I'm guessing 211 sends people to the AAAs. They don't send people to Maximus because they can't process what needs to be done.
Right, it's supposed to be if they have asked them the questions. And they answer the questions the right way, they either send them to the AAA or they send them to Maximus.
Who 211?
211.
I can't speak to the specifics of their process, but that's my understanding of how it is supposed to work, but
So when you guys get call comes in and it's supposed to be to Maximus, do you help them call Maximus or do you explain to them what to do?
Like if it's somebody who's calling in who's supposed to be like for pathways or something, we help try to facilitate it. I hear different stories and we could go on and on and on with different stories, but we do the best for the person who's calling us to try and get them to the right place.
And the call, and Maximus, when they're processing someone, is it correct that Maximus only calls the person for whom the service is? They don't call the caregiver. So if somebody has dementia, can't deal with the phone calls, they just get dropped off. Then they'll end up back at the AAA again. So I mean, there's something not kind of, I got caregiver questions here all over the place. We're just trying to be different.
No, it's okay.
Let's
If
work
they have
through it.
information that there is a legal caregiver, somebody that they can call that person. They just need they just need to know that they're not randomly calling someone who doesn't need that information. But they can speak to a caregiver.
I'm so sorry. I don't mean this the
Yeah.
wrong way.
No.
Who are you?
Hi, absolutely. I'm Vanessa. You'll hear more from me later. I've got like 2 different presentations for you today.
Okay.
One of them is just a really brief version of some changes to LCAR, specifically around PASSAR. So we'll get more into it then. But my name is Vanessa Convard. I'm the Service Enrichment and Advancement Director for the Division of Aging.
Okay.
So I manage APS as well as PASSAR, as well as our community outreach efforts. So, hi. But yeah, I just wanted to get that out there. They can call the caregivers.
And we've been told they cannot.
Okay, if they know, they have to know, like, it can't be informal just because of PHI, right? So they have to be able to know that, like, legally it's okay to do so.
So you do that.
It depends on if they have that information or not. It depends on how they receive that call and where that information might be coming from. So if they're getting it through an assessment and there's guardianship information loaded to that document, then they're gonna know. But yeah, otherwise it's a challenge if they don't have that exact knowledge. That can be quite a barrier.
I mean, seniors are afraid to answer their phone.
Yeah.
I mean, there's so much not like stuff out there.
Yeah.
So if somebody calls 3 times and they give up, that's not doing much for them.
Yeah, and they don't have like, so you'll hear them when they talk about this, be a little vague on like the amount of times or that kind of thing, because what they really try to do is just as many times as they can, right? It's not like we called 3 times, we're done now, we'll never try again. It's, yeah, no. It's not 3 and done. They will keep trying if they know that it's a situation where they have to keep trying, or if they can't, then it needs to be resubmitted, then they will keep trying again. Yeah.
Well, we just need to listen as things have switched around here a little bit to be sure people are getting what they need, but sounds like it's not as simple as some of us thought it was going to be in the beginning.
Yeah.
It's like, I'm gonna say this, it's like when the state did an IBM program and closed the welfare offices and thought people could, use the computer to do the applications, and they couldn't do it. So it's kind of like the AAAs have a role in here. Somebody beyond 211 has to sit down and talk with a lot of people. I'm doing it. And we want to be sure this is done or it won't happen.
Yeah.
That's where we are. And I know there were funding cuts, and I know if you're not familiar with what the population you're dealing with, you could say, oh, inefficiency, we'll just do this, this, and this, and it'll be so much less costly. Well, that's wonderful, but a lot of our clients take some time, and time is money. And just wishing it through a system sounds good to probably a legislator who may not be aware of how much time. I mean, you go over things 5 times and somebody's still, you do a teach back and you haven't gotten there. And then somebody has to help them with the call, what the process is, and they'll call back 10 times. And so it's not one phone call, it's not one contact. It's that kind of thing. So I think we're in a process. And I think to your question, Deb, is this working?
Right.
We kind of removed the helper.
Well, we've removed our client, right?
Well, kind of so. Okay, so we're working, we're just trying to do due diligence on our side from a high level look at it. But we're concerned
Yeah.
because we know some of the helping has disappeared. And these folks are, a lot of folks, they're expensive because you have to go over things so many times. And you can't do it fast, you just can't, you can't. Not a few, but not most. So efficiency. Yeah, I need to be quiet. Anyway.
So you're not wrong. I'll
But
turn
thank
this back
you
over
for
to
the-
Aaron, but
We'll
yeah, we'll talk more about it in a minute. Yeah,
But-
thank you.
Yeah, it's hard, but thank you.
Yeah.
All right. We'll try to be quiet once you do your presentation.
Okay. All right, we have about an hour left. I'm going to quickly go through the 16. So planning and service area 1, co-action. They requested 1 direct service waiver for health promotion, evidence-based services. They are really focusing on strengthening their transportation and nutrition access and really improving outreach and service navigation. They are currently delivering daily hot meals in all of their 6 counties, which is relatively unique for across the state. I think they're one of the, it might be the only that is doing daily hot in all their counties, not in all the area 2 and so a couple of them are, okay. So area 2, in northern Indiana, they had a number of direct service waivers, primarily related to their caregiver services as well as nutrition and transportation senior center. And they are really focusing on expanding health promotion in their rural communities. Area 3, Northeast Indiana, had several direct service waivers as well, primarily again related to nutrition and caregiver services and some health promotion. And they included a goal that they're really trying to increase the number of calls that are live answered in their ADRC. Area 4. Sure.
It says it has a unique restaurant voucher for it.
Yes, and actually, Christy, can you explain? Yeah, I think you can explain it better than I. But you can say what you're good. Yeah. This is Christy Garner. She oversees our nutrition and health promotion programs.
So with the restaurant voucher program, they have contracts with area restaurants or either hospital cafeterias. And the older adults can go and get meals at those establishments. And they still meet the daily requirements because they're special meals that they can choose from.
Can I ask what an ABC community is? I see a couple.
So ABC Community is the program that started out as a pilot program through a grant from ACL under the Alzheimer's Disease Prevention Initiative funding. I think that's what ADPI stands for. Essentially, it's caregiver support and training for individuals with dementia.
Okay.
And it's a partnership with IU. And probably Shannon can better. Oh, she's gone back. So we with, and Dr. Council has shared some program updates about the ABC community over the last, probably might have been a year ago now or 6 months, but we all of the grant funding had ended and we were able to transition the ABC Community Program to fit it in with some of our Older Americans Act and choice funded programs. So we've been able to sustain the program in, I don't think it's quite half of the AAAs through grant funds or through Division of Aging grant funds. Okay. Area 4 is really focusing on the direct services with health promotion and transportation. They are also looking for ways to improve their congregate nutrition program to really try to focus on social isolation. And actually with the new Older Americans Act regulations that were passed over the last year or so, socialization is really something that's highlighted now as a part of the Older Americans Act. We started talking about it more during COVID, and it's been codified in Code of Federal Regulations related to the Older Americans Act. All right, Area 5, their direct service waivers are for their nutrition program. And they are trying to continue to support older adult population, physically, socially, emotional wellness, health maintenance, and medication management. Area 6, direct service waivers related to evidence-based and non-evidence-based health promotion, as well as transportation. And they highlighted they're working to increase volunteer opportunities, as well as looking at doing basic home repairs, safety repairs to try to support independent living.
Could you give me an example of the difference here between health promotion evidence-based and health promotion non-evidence-based?
Yes, and that is rooted in ACL's definition of what an evidence-based health promotion program is or non-evidence-based. The evidence-based health promotion programs have to meet a laundry list of criteria. They have to have been through scientific studies with control groups, with older adults. They have to have published results. There is a list that outlines all of the, and it just has to be proven evidence-based by one of the Federal Health and Human Services 11 divisions. So there's a whole list of services that are can be considered health promotion evidence-based. Through the Older Americans Act, we receive a bucket of funding, Title III-D, that is strictly for those health promotion evidence-based programs. The non-evidence-based programs are, pretty broad in scope. It could include health assessments, certain kind of exercise classes, just anything that would fall into health promotion, but hasn't been through that kind of scientific study.
All right, thank you.
So like bingo size, powerful tools for caregivers, chronic disease self-management. Those are some of the examples of evidence-based programs.
Is the non-evidence-based?
It's, yes.
I'm wondering about.
And that's actually in looking at the definition and consulting with the Administration for Community Living. That's under the Older Americans Act. That's where we have the community health workers. Stuff that SACOA is doing is in that bucket.
In the non-evidence?
Yes, because the model that we use is not one of the ACL approved evidence-based programs. It's still evidence-based, just not by those same criteria.
Okay.
It's the list.
Yeah.
And then there's a workaround for the list, but it's really, there's a lot of scrutiny. So I still don't think it would. So it's just a different bucket of funding.
Okay.
Okay, I'm gonna try in Area 7, evidence-based transportation. Well, They really talked about their plans to better support individuals with dementia in their plan, as well as working on opening 2 rural congregate meal sites. All right, Socoa. They'd requested direct service waivers for handy chore and occupational therapy. And those programs in particular are kind of working hand in hand, where they'll go in and do a kind of a home safety type assessment with the occupational therapy. And then if there are any kind of minor home modifications or those type of, I'll just say, tweaks or modifications in the home, the handy chore can support that. They also had the evidence-based and non-evidence-based community health workers we just talked about, some of the nutrition services and some caregiver supports. And I jumped ahead and mentioned the home safety and accessibility, so we can move on to number 9. Area 9, Eastern Indiana, Lifestream Services, Health Promotion Evidence-Based Direct Service Waiver. See, last year they touched over 19,000 older adults. They're going to continue offering the ABC community and also really looking at home accessibility and safety type interventions. And we saw that actually quite a bit through all of the plans. And I think, you know, with the changes in the choice program that I mentioned earlier, it all kind of aligns nicely with at least in particular where that program is refocusing in a way. Okay, Area 10, Monroe and Owen counties, their nutrition services, they've requested direct service waivers as well as health promotion services and transportation. They talked quite a bit about how they are coordinating transportation services with other available services in the community to try to kind of wrap around and fill in gaps. Area 11, health promotion evidence-based direct service request, and also the caregiver ABC community. And I don't think I said ABC stands for Aging Brain Care. And they talked quite a bit in their plan about their caregiver supports, particularly around dementia. Okay, Area 12 requested a number of direct service waivers, some caregiver supports, transportation, education, health promotion. One of the only ones that particularly called out socialization for the direct service waiver. And I think that relates to their efforts to enhance their nutrition education and promoting physical activities and health related to chronic disease. Okay, Area 13, which is Generations at Vincennes. Their direct service waivers relate to a number of the caregiver services, as well as evidence-based health promotion and nutrition ed. And they talked about in their plan, their work to elevate the ombudsman services. We haven't really talked about ombudsman a lot through the area plan process, but that program, because it's funded with the Older Americans Act, is also addressed through the area plans. Okay, Area 14, Lifespan Resources, requested direct service waivers for nutrition services, again, health promotion evidence-based and transportation. And they talked about through their plans, trying to really focus on those core Older Americans Act programs and looking for opportunities to address any gaps in targeting services. And they're also working to establish a centrally located they refer to as a campus that will have a senior center in their service area. Okay, area 15, Hoosier Uplands. They did not request any direct service waivers, which means that all of their services, with the exception of those that are exempt, they are through local service providers. They're not providing any of them directly. And they talked quite a bit about how, because they are an economic development corporation, they really have a lot of opportunities to work with other programs and divisions and kind of leverage and wrap around services. And finally, SWRCA, they submitted a direct service waiver for their nutrition services, and again, health promotion evidence-based. And they really highlighted their use of data in the creation of their plan and included some specific information about outreach related to legal and as it relates to the multi-sector plan on aging. As I said, we've gone through a very intensive review process using standardized tools. Some general observations that we are working with the AAAs to address. Some of them had just a lack of detail and specificity related to the requirements or even incomplete sections. We were missing some direct service waiver requests, and this kind of leads into the next bullet. There was just some inconsistency between some of the sections in the plan. For example, we saw on numerous occasions that they had service projections for, I'll just use congregate meals as an example, but I don't think that's a real example. So they will say that they are projecting to serve X number of meals, and the projected funding was through the AAA, but they did not have a direct service waiver request. So we're looking for kind of that alignment and consistency and working with the AAAs to request revisions for that. I wanted to, because I'll take a step back. I intended to really kind of highlight an overall projection of number of individuals that were projected to be served by service across the network. But because we're sort of still in the midst of this revision process, I just pulled out some information on the projected expenditures and the percentage. And this ties into the direct service waiver requests. So the pie chart on the left are the mix of services that will be provided through the AAA's issuing grants and contracts with local service providers. So about 60% of the funding that's going to local service providers is supporting the in-home services, whether it's the attendant care, home and community assistance, personal emergency response system, et cetera. About, oh gosh, 30%. Grab my glasses. There we go. 20% is on nutrition services. And then about 7% is the access services, which is information and assistance, outreach, transportation is in access, and that's only 7%. And then the smaller percentages are for the service categories of elder rights, caregiver services, and that health promotion. The pie chart on the left are the services that were projected to be provided and funded directly through the area agencies on aging. So about 60% are for those access services, which is case management, information and assistance, transportation, outreach, public information, that's all in access. Nutrition was about 30%. And as I went through those direct service waivers, there were a number for nutrition services. So that's what that is. Those in-home services, is about 4%. And then, caregiver services and elder rights were smaller percentages. For some context, and this is just based on the grant funding, so Older Americans Act, Social Services Block Grant, and Choice Funds, not their local match or program income. The direct expenditures as proposed through the AAAs was about 40 million for the pie chart on the right and 30-ish million on the left. So just to provide some context for how the funds are projected for the next 2-year cycle to be distributed throughout the state. I will pause, see if there are any questions. And we're continuing to work with the AAAs to address any questions and issues with their plans.
Wow, okay, this was a lot of
It's a
work,
lot.
really appreciate that. And you think across Indiana, the urban areas, the suburban areas, the rural areas, and the changes that are going to happen as a result of funding cuts. This would be very difficult to put that together, knowing there will be significant changes coming. I mean, I'm thinking about they're not small. I mean, things like local communities don't have external funding now for welfare checks on older people with their fire and police going in to do welfare checks. There will be ambulance transfers over to hospitals that, and some local communities are starting to charge for this. We don't have people who have money to do this. What are we going to do with them? We don't have answers. So these are things as we come back to local communities with no infrastructure to deal with this. And all people like me, what are we going to do with this? We are there. I mean, I don't know what we're going to do with this. And boy, caregivers, family caregivers, and formal and informal caregivers, wow, we really need them. But we are challenged right now to find some new solutions. So this would be very hard to put together in terms of they don't know what's coming. And people are confused. They don't understand. They just don't understand what is there and what isn't there and how to get there. So we're going to be kind of challenged to find some new solutions. We're not we are going to be challenged. We haven't dealt with this. All of a sudden, people have been used to something that was there that's gone. And we don't have county homes anymore. And things like that. And there was a reason we don't have them. But now we also don't have any sources of revenue at local. That's why the welfare checks, I brought it up, because of some changes with funding and formulas for counties, they have less money available.
Not only that, but less like our police officers, we're down some men, it's ridiculous. They just don't have the law to do it.
Yeah, well, we're gonna have to roll up our sleeves and say, okay, now what kind of country do we want and how are we gonna help each other? And so we're gonna have to figure some of that out at the local level and then go from there. But this was a lot of work, and thank you to the area agencies on aging, all the work you put in and the division. And I know you tried to include the multi-sector plan on aging that we worked on a lot last year. The caregiver piece really comes up for me, formal and informal, because families don't know what's coming. And we have those in the community who don't have families who can or will or don't or whatever. We got a lot of those folks too. So I know Vanessa's going to talk a little bit about some of those things. So, and thank you. That was a nice overview of it was a very lot.
Thank you to your staff, Erin.
Yeah,
thanks to
thank
you and your
and
team.
staff. Thank you. And the AAA. Yeah. Okay, very good. All right, and if anyone has something, you think about, please get to, let Erin know if something comes up that you think about it. Like to address. Okay, we'll move on to our next part of the agenda, and Vanessa, you're up with Adult Protective Services. A growing need.
Hello again. Oh, I thought that's full of hope. So once again, hi, I'm Vanessa, Service Enrichment and Advancement Director for Division of Aging. Actually, if you want to pop over to the next slide, it will show you everything that I do. Oh, I lied. That's in the LCAR slide. Whatever, we'll jump into it. Back here in the corner is Pravi Najaj. She is our APS Director. She'll actually be the one giving this presentation this afternoon. So you'll get to know her a little bit more as well. She just came to us, March? End of March? Yeah, yep. So, so she's really like jumping into taking over everything that happens post-transition for Adult Protective Services. Since it's not in this particular slide, once again, APS as well as PASSAR / a good portion of LCAR and our community outreach efforts are the things that I manage for the Division of Aging. So essentially anything Erin doesn't do, that's on my desk, right? That's how that works when it's a small office and there's two of us. So, all right, so let's talk a little bit about our APS changes. I've got my notes up here ready to write down whatever questions you might have for me, because I can pretty much guarantee that both for APS and our LCAR conversation, you're going to have questions that I'm going to have to take back and just get back to you on answers later. I'm just assuming that's going to happen because these are two really big transitions and a lot is going on. Okay, so what is changing? So as of July 1st, we have a new contract. APS is no longer housed within the county prosecutor hubs. We went through, a competitive procurement process, and we are now contracting with PCG Indiana, that's Public Consulting Group Indiana. They will be our statewide provider. Our investigations are going to be managed by 5 regional teams. So once we are fully staffed, which we are very close to, but if you know anyone who's looking for a job and does social services, you let me know. We're still hiring a handful of people. So eventually, when we're fully staffed, we will have 45 investigators, 5 supervisors, 1 per region, plus 3 case monitors. And then we also have an operations manager who is over all of the regions.
How many APS people did you lose in the transition?
If I remember off the top of my head, I think we got 13 incumbents who came over.
Out of
I think I can go back and look at the numbers, but I want to say we were at 50-ish, not all of them full time. So that's one thing to keep in mind when we talk about the numbers shifting, because it seems like quite the drop. But a lot of our previous APS staff were part-time, and all 45 of we're full staffed, will all be full-time. So that just as a side note. So we're going to be using standardized tools. The big purpose of this transition and the big piece of the part where we were like, okay, we got to do a thing. This is going to be rough, but we can bring a lot of positive out of it. And one of the big ones was consistency. So simply going from 17 different hubs that did things 17 different ways, as I'm sure you've heard before with every social service program, that is simply how it goes. Now we're going to be 1 statewide program with 5 regional teams, which helps to improve that consistency right off the bat. But also, we're now able to do things like create standard operating procedures, which we could not do before. And we continue the consistent training that we've been having. And we're also going to have more standardized tools. So different units before used different tools, whatever they felt worked best for them. We're going to narrow that down to the things that we think are going to work best and that, are not proprietary. And then make sure that everybody is using the same tools for the same things, right? that everybody has the same timelines, which was not necessarily the case before. There's also going to be a new statewide email address specifically for incident reports, which again, we did not previously have, so that'll be really nice to have.
What's the timeline for that?
It happened July 1st. It's happening
It's
now.
out there. Okay.
Yeah, it's
All right.
happening right now. So things that are not changing, mandatory reporting, right? That's state law. Everyone in the state is a mandatory reporter, and we still have the same reporting process. So it's still the same hotline number. We are still partnering with 211 for that work. And we still have the same web portal that we had before for submitting APS reports. So people can still do all of that just the same. None of that changes. We are still investigating the same things we investigated before. Again, that's all in state code, so we're still doing all of that. We're still connecting people to community services as before. All of that is still the same. Client rights are still the same, etc. Our state APS email is up there too, in case you have questions in the future that you want to ask us, or if other providers do, other, if general public does, whoever, you can pass that email out to them. All right, so we're going to talk just a little bit about who PCG is. So PCG has been around for over 35 years. They have done other work in Indiana, particularly around first steps and early interventions. They've had programs in all 50 states. So they have been doing human service work for quite some time now. They have quite the expertise as far as Medicaid, child welfare, et cetera. And they have done APS work in other states as well. Again, this is just giving you some information on how to report. We just try to get that out there any chance we can so that people know. I don't know that every provider is aware that the APS report portal exists. So we're really trying to get that one out there for people so they know that if they don't feel like they have time to make a phone call, or if they think the line is, if it's taking too long or something, then they can go to the report portal and put all the information in there, and it goes to the exact same place. That's actually the same portal that the 211 group uses. They log into that portal and enter in all the information. So it's just the same. And then for any incident reports, those can go to that email and they'll be fielded from there. So all of our reports are going to be screened using a statewide risk tool. We have case prioritization. We call them priority A, B, and C. So taking a look at, our more severe cases, of course, where we need a quicker turnaround time are going to be under A, so on and so forth. B, C, less of a turnaround time. Previously, and it's still written in code that they have up to 30 days, I think it is, so from maybe 20, to go out and investigate a case, to initiate a case. But we have changed that in our SOPs, and we have changed that expectation for people for those priority cases. So now they have shorter timelines for those higher priorities.
What is that?
So it's 24 hours for priority A cases. And I literally cannot remember off the top of my head right now because it's just not coming to me and I don't know why. Do you remember off the top of your head? I know, I'm so sorry. Let me write that down real quick. I can get that to you. We were heavily focused on A. And then we also have our investigators continuing to conducting face-to-face visits, which was not necessarily a requirement previously, and was not often done. So now we have a requirement for a face-to-face visit to be completed. Yeah, we were pretty excited about that one too. And for the standardized risk assessments to be done, and of course to coordinate voluntary services. That's another one that we were really excited about, is that there's a requirement now that there has to be a service plan for every single person. And that was technically a requirement before. It wasn't happening. It is a requirement now, and we have our case management system set up in such a way that it absolutely has to happen.
So for every case that comes in,
There has to be a service plan.
you have to have a face-to-face with people who filed a complaint.
With the people who are the alleged victim. The alleged victim or victims, because there can be more than one on a case. There has to be a face-to-face visit at some point.
Yeah.
I'm just curious, what's your percentage breakdown of ABC?
You know, I am not sure what that percentage breakdown is. I can look that up.
Thank you.
Yeah. And if we don't have it now, because I mean, we just started this, right? We can definitely add it to the list of things we track. Because there will be tracking. So that's the other thing that's going to be changing that we're really excited about for this new program is that we're going to be developing a quality assurance process, which previously we did not have. So now we get to do that, and that's exciting. So we'll be getting that going here soon. So these are the commitments we have for this transition. Uninterrupted access to APS reporting and investigation. So one of the things that made the transition a little easier is that we already own the APS case management system, right? The state already owns that. We got that developed with ARPA money. Thank you very kindly, federal government. So we already track all of that data. We already own that system. So we just had to give PCG access to it. Which means we can gather whatever data we want to gather. We can pull whatever report we want to pull. We can do it at any point that we want to do it. It's ours. So that was really helpful when making the transition because it was a lot easier to just up and transition the cases. Like, oh, this person, it was essentially the same as if somebody had left and somebody new had been hired, right? Take it off this person's load. Now it's going over here. So that was a pretty easy transition as far as easy and, data transition terms go. So same thing with all of our court cases. All of that is logged into the system. So we had all that information. We can transfer all that over and make sure that nobody misses a court case, right? That we're still showing up for these. And we also had the APS unit directors send us that information just in case. Just in case there was one that, got missed or didn't get entered into the system prior to the transition, that we would have all that, we'd have that safety net to double check and make sure. And they were fantastic, by the way, with giving us the information that we needed in order to make the transition successful. So that was really wonderful. And several of them have come over to the new system.
Do you know what cases you said right now?
I don't know off the top of my head how many court cases we have. Sorry. So we will be working closely, of course, FSSA and PCG to make this happen. Right now we're meeting 2 to 3 times a week. That will continue for probably the rest of the summer, at least, until we feel like they are at a place where we can reduce that. But we are definitely meeting very regularly. Even when we don't have meetings, we talk every single day. So it's just one of those things where the partnership is close. We are working very closely together to ensure that this is successful. This is our regional map. So these are the 5 different regions. I mean, that's pretty much all it is. And their names are just the most easy thing you can imagine. So now we've just got, Northwest, Southwest, Central. Makes life a lot easier. And then this gives you some resources in case you feel like you want to dive into some stuff later. So when I talk about like, oh, per Indiana code, this is what I'm referring to. We didn't go into the federal rule today because that's we ain't got time for that today. But we gave you the link for it. So if you want to dive into what the federal rule states, when we were working on designing this, we were definitely taking that into account, right? What are going to be the expectations of the federal rule? What are the current best practices, the voluntary consensus guidelines, which those things from the National Adult Protective Services Association are actually what the federal rule is heavily influenced on. So taking all of that together and then thinking about what has worked well for Indiana and what will need to continue in Indiana and what the state laws are in Indiana, really doing our best to take those expectations of the federal guidance and apply those to this program in the best way that we can without undue administrative burden. So that has been a big focus for us. And as we move forward, we're also looking at developing multidisciplinary teams, implementing the RISE model for APS. We are looking at how useful, like the tools that we're currently using, we're going to be monitoring that to make sure that we feel like they're actually working and giving us the information that we need. We're going to be getting that quality assurance process together. And we're going to be very much just data, right? Paying a lot of attention to what is going on out there, what the timelines are looking at, looking like, making sure that the providers have everything that they need. So there's going to be a lot of like communication happening, and at some point we're going to get some kind of a survey process in place. That's going to be part of the quality assurance. So we've got a lot coming as we move forward. We're really, really excited about it.
It's the RISE model.
Oh, the RISE model. Okay, so I believe that is in the resources, and if it's not, I will email that to you.
So there's.
Okay, good. So the short version of the RISE model is that it's actually one of the few models that's been developed for APS. And one of the people who's actually the person who's our contract manager for PCG for APS, Erin Salvo is her name. She is one of the people that developed the model. So bonus. But it's a model that is based heavily on developing a good relationship with community networks to try to create a support network for people to help prevent them from getting into APS. And it has been proven, and I have articles on that too, if you want them. It has been proven is a strong word when we're talking about studies, but it has been shown to reduce the recidivism of people who come back into the APS system. And that's a really big deal to us. So that is hard to do. So, and the reason that it works is because the whole purpose of it is putting a support network in place for people so that they don't have to rely on APS, or they don't get themselves into a situation where that abuse or that neglect is occurring, because they do have some support. They do have a network. They aren't so isolated. They aren't, without the necessary resources. So that is the purpose of that model.
Do you foresee with this shift and being data-driven, that there might be an opportunity down the road for the department to partner with like senior care providers on educational, like, this is our ABC, this is kind of the issues we're seeing. So these are things to be on the lookout for as they come to your senior centers or as they come to wherever they come to.
Yeah, we'd like to see a lot more of that happening in the future.
Yeah.
Yeah. We want to do way more. We want to expand our outreach and our connection with our stakeholders. At the state level, we didn't get to do as much of that before because that responsibility was placed on the shoulders of the units. And now we are taking that back and putting that onto our shoulders to make those connections happen. That's great.
So I own an investment firm.
I'm so sorry, say again.
I own an investment firm.
Okay.
And I see financial scams every single day. I was able to call my local and talk to them, my local APS, and talk to them to see what they could do to help me.
Mm-hmm.
Not always do I get help. And they're guaranteeing me now that I will get help no matter what.
That well, as long as it qualifies as an APS case, I mean, you know what I mean? We'll do everything we can. Yeah.
So grandson's taking care of grandma, he takes all of grandma's money, grandma has to go to a nursing home on Medicaid, what are you gonna do?
I mean, we'd have to dive into that situation to look into the details of what's going on. I can't promise she's going to get her money back. That is an extremely difficult thing to do. But if we have any evidence of criminal activity, we might be able to refer to law enforcement on that aspect of things. Financial exploitation is an interesting one because depending on who the perpetrator is will change who we might refer it to. But in that particular case, that would be a law enforcement issue. So we would be referring it to law enforcement.
So
And then we would,
just go straight to my own police then?
if you would prefer that, you could. But the difference between them and us is they're going to be able to do the criminal aspect of things, which obviously we cannot do. But the pieces that we can do are check in on her, make sure she is okay right now, make sure that that person no longer has access to her accounts, and to the best of our ability, make sure that person no longer has access to her accounts, and make sure that there isn't anyone else in her life who is trying to do the same thing. Like, just because you remove that person doesn't mean it isn't going to be a vacuum that's filled. You know what I mean? So making sure that she's going to have the support she needs around her to prevent that from happening again.
I have found that just threatening family with the call to APS changes behavior.
It can. Yeah.
Yeah. A lot of people don't want to go under that microscope.
Yeah.
Well, but it's not really a microscope. I mean, if there's no, all they can do is just make sure she's doing okay. How is that a microscope?
No, that's not all they do. No, anytime, and I've had APS involved in some cases at our community, and they literally come in, they start to investigate, they ask for documentation, they ask for proof that the funds that the grandson is diverting is truly going towards grandma, and when they find out it's to buy 6X clothes for grandson's baby or child, then they do step in and they do make a difference. But most of the families, when I tell them what they're doing is illegal and I'm going to call APS on behalf of their grandma, they'll simply stop doing what they're doing.
Okay, so they step in, what do they do? They step in.
I just described to you what they did.
That's what they
I
do.
just described it to you.
APS.
Yeah.
Yes, ma'am.
But I think, if I understand, if they see there's alleged criminal activity, they will make a referral.
Yep. They make a referral to law enforcement, and mostly it'll be law enforcement. It could be Secretary of State, or there's a couple other options.
Could be
depending on the
attorney.
type.
So they're-
Yeah, it could be
they're
Attorney General, but
Prosecutorial
yes,
part of this.
yes.
They just don't do it. It'll be law enforcement do it, but
Right,
they
we
do
just
step
can't
in and do something. They just don't look and say, well, you know, that's a police matter and walk out.
Right.
Or law enforcement matter.
And they are expected to, and this is very much a part of their training, and it is in the SOPs, they are very much expected to work very nicely with law enforcement to coordinate those services, right? So it's not, when I say referral, I don't just mean send a piece of paper off to law enforcement and be like, this is your problem now. They are expected to still continue with their piece of the case. They are expected to communicate with law enforcement to find out like what it is they need from us and what it is that they can go, whatever we can do to support the work that they're doing. So trying to work in tandem and have more of a partnership, not just hand it off and then close it and call it a day. You know what I mean? Like actually work together to accomplish the goal.
So I think
Gotta have
they've added service to it that wasn't there before. It was more law enforcement before. is that-
Yeah, it depended on the unit before. It might just be referred and then closed out and they just said, well, it's criminal, so we're not doing it. And that was that. Or they might work very closely with them. Or if you were in Marion County, they were deputized, so they could do it themselves. But we can't deputize people, so that will not be continuing.
Did you have a comment? Or?
Yeah, well, address to this question, I have this question, if people are dissatisfied or they're having challenges with APS, who should they email? Should they email the APS at FSA or the incident?
APS at FSSA.
Okay.
Yeah. If there are any concerns or questions or anything, email the APS at fssa.in.gov. The incident report email is specifically for an incident report form. It's actually for DDARs. It's like in state code. It's a thing that providers have to fill out if there's any kind of an incident that happens in their facility. So, yeah, thank you.
Okay, well, thank you very much.
Absolutely.
See how this moves along. It's new
Yeah.
and, but it sounds like it's a strengthening of what we had here in Indiana. It
Yes,
didn't work too well
for a long time. Yeah. So we have a lot of hope.
and
for this.
standardized across the state.
Mhm.
That's, it was spotty before.
Yeah. Just seeing the consistency alone is going to be great. All right. Thank you.
And you also are doing the.
Oh, yeah. I'm still up. Still me. Okay. I can do this in 15 minutes. Sure. Let's do it. All right. Let's talk about PASSAR and LCAR. So there it is. That's the slide I meant. There I am. Those are the things that I manage, and that's how you can get a hold of me if you ever need to.
And we'll get these slides as well.
Yeah. Yeah.
Thank you.
And you are welcome to email me at any point. I know I keep telling you to email APS at FSA, et cetera, all that jazz. That's what we tell general providers, general public, but obviously if you directly have any issues, like, or if you know of a provider who has any issues, like, you can just email me. All right, so we're going to talk about in our brief time here, we're not going to go into all of LCAR. I cannot answer all of those questions. LCAR has transferred over to DDARS, but I can answer what I can answer, which includes anything to do with PASSAR. Still very much involved with the communications team. And also I'm still on like pretty much every single meeting. So I can answer a lot of those questions as well. But again, I have my notes in case you have any extras that I cannot outright answer right here and now. I can say to Judith and to everyone else here that I double checked with Maximus in between my being up at this podium. And yes, if they know the person is a guardian, they absolutely can speak to them. And in fact, even if it's not a legal guardian, if the person who requires assistance says, hey, my caregiver is my spouse, please talk to them. They will be able to give you more information. They can do that. They just need that person to say that it is okay, and then it's okay and they can do it. So yes, that is a thing they can do. All right, so yeah, let's jump into it. Let's see what's changed and what's still the same. All right, so we're gonna talk a little bit about how PASSAR relates to LCAR. That's just the basic purpose of PASSAR. Appropriate service, appropriate place, appropriate time. That is what it's for. And if you're not sure, because I know most people do not get too deep into PASSAR, it stands for Pre-Admission Screening Resident Review. And it's something that was started in the Omnibus Act, I think in '83. And the entire thing is exactly this. It's to make sure that we're not institutionalizing people who don't need it. Okay, so LCAR is Level of Care Assessment Representative. Currently, Maximus is the LCAR vendor. And the purpose of this is to combine the PASSAR and the HCBS waiver functional eligibility process. We were already using the same assessments, but they were just being done by multiple agencies. So the purpose of this was to streamline that functional eligibility process, again, trying to come up with a more consistent way of managing the functional eligibility. This is rule changes in general, but because of the PASSAR aspect, like AAAs were the ones previously who were the only ones doing it for the waiver, but AAAs, hospitals, and nursing facilities were doing the level of care assessments for PASSAR. So all those roles have shifted somewhat. The AAAs being, of course, the biggest change. The hospitals still complete level of care forms. They used to do what we called the short form. Now they do, it's called the long form. We don't have a short form anymore. It no longer exists. Nursing facilities are no longer completing LOC for initial admissions, but until 2026, they will continue to do them for people who are already in the facility and need a continued stay.
So who's doing that?
Maximus will be doing
Every.
the ones from the community and the ones for people who are entering a nursing facility initially. Except if the person's coming from a hospital, in which case it'll be the hospital.
Do they know that?
Yes.
Okay.
Definitely. I just talked to them last week. They know.
Okay, I don't know hospital that doesn't, but okay.
Okay, you feel free to send them my way. We have had many a training with the hospitals and just did a presentation in person, actually up in Fort Wayne, with the hospital systems there. So if they don't know now, please give them my email address, direct email right there. Yes, please do. So yeah, no longer short form, only a long form. There are also two new inter-eye assessment tools. So previously we just had what we called the HC, the home care assessment. And we did that for all ages. Now we have two more tools which are more appropriate for younger ages, and that's the pediatrics tool and the early years tool. So pediatrics, as you can see, is 4 to 17, early years is 0 to 3. So these are, look, this is my favorite. I just got to bring this up because it's kind of amusing. This is my favorite example of why we switched to having some peds tools. You think about a 1-year-old, one of the things that's on the HC LOC is how far they can walk. That's not gonna give you the result you think it is when you're talking to a 1-year-old, nor are you talking to a 1-year-old. So we instituted these to be more appropriate forms. Some changes with level of care, or I'm so sorry, yes, thank you. So these are some basic resources for LCAR and PASSAR. That's the role changes, like the full guide. This is where you have the provider support resources website. That's where people can go for training. So there have been multiple webinars and communications sent out and Q&As and such. I don't think the Q&As are all on there, but all of the trainings that were done are, all the webinars are, and all of the communications that were sent out are all in there. So if anybody requires like some education around these transitions or what their role might be, it's going to be at that link. And then the final link is just our general Indiana website, and you can go there to just learn more information about LCAR.
Okay, I know we're short on time, but I have to ask this question. All right, people in times past were used to saying, I can't take care of my older relative anymore. They would go out to the nursing home and they go in the nursing home would file the Medicaid papers and they would, they take them Medicaid pending. There are very few nursing homes now taking Medicaid pending. I think I'm correct on that. All right, it seems to me, and somebody correct me here, because I've been getting questions. About the only way to get in and get things expedited with Medicaid and get something done quickly, if you think you can't take care of somebody and you can't wait for months and months for waiver services through Pathway, somebody has to go to the hospital. They have to stay more than 3 days. Is that right? Unplanned?
I honestly can't speak to that because that is the Medicaid policies and I do not oversee the Medicaid policies. But I can write it down and get you that answer.
I want that clarified for September meeting. How are people getting care now whose families don't know that they can do it without help, and they can't get the help because they have to wait through a very long Medicaid approval process and be waiting. If they do get, then they have to wait for months and months to get a waiver. I mean, are they just dropping them off at the hospital and saying, I can't safely take care of, I'm not, that's the word, safely take care of them anymore? And then we have to go through the long form. And is that how you get expedited Medicaid unless you're in an assisted living situation now and they got expedited? I don't know where that is now. I think we need, as a Commission on Aging, to understand what is truly going on out there. Now, that's not a criticism of the state staff or anything else. What on earth's going on with people?
Sure. And I can tell you that people can directly call Maximus, and then if they're, appropriate for nursing facility, of course, can be referred there.
Yeah, but you're
like-
still in this thing of what?
Yeah.
And that's your question on what's working in Indiana.
Mm-hmm.
I think the commission, we need some updates from OMPP and some other things, because your questions are,
Mm-hmm.
what's going on with people? How do I get care now? And I think what I just said is that's about the only route if can't do it anymore and you're in difficulty. And I don't think that's what the intent was, to drop people off at the hospital and say, I can't safely take care of them and leave. And that's the only route to services now. Is that what we wanted? I'm asking the question. I didn't know if I had the guts to do it today, but I just did it.
No, I think that's extremely valid. And I feel like one of the things I'm hearing you saying, correct me if I'm wrong, is how do people know? So they can call them Maximus and they can still get the assessment done and they can still enter a nursing facility that way if they feel like they need to. Do they know that?
I wouldn't know how.
Right.
And
So
you still have to get Medicaid approval. How long does that take? Is that expedited then?
I think though,
The waiver services is for home and community-based services, which is restricted to assisted living.
Yes.
So if the goal of your example is to move them into assisted living, then yeah, they're gonna be put on a wait list and it's gonna be
Yep.
a little difficult. If their level of need is beyond what an assisted living waiver provider can provide, then they still have the opportunity to get on Medicaid, which would be, it's my understanding, traditional Medicaid in the nursing home. And so I don't think that process has the wait list.
Nope.
That the home and community-based services waiver program has. So the wait list at this time, now who knows what it's gonna be in the future, but at this time, that wait list is still simply, and I shouldn't say simply, it's restricted to home and community-based services waiver, which is different from payer source from long-term care.
So you still get into a tradition, when you have a check, how long does it take to get approved for traditional Medicare?
Medicaid. So that, it depends on how quickly the person filing is forthcoming with the required documents. So some people are more cooperative than others. Some people get attorneys that help them through that process, and so forth and so on. So there's not as big a delay if they're truly going into a nursing home, because that is at this time still traditional Medicaid.
So so the level of care assessment is done by Maximus.
Mhm.
And the Medicaid application for traditional Medicaid is done with however quickly that can get done. And
Yeah.
because it's an entitlement, they're still able to get into the nurse.
Yes, a lot of facilities assist people with that, but again, it's a matter of how quickly they want to
You don't go
disclose.
in pending.
You can still go in pending.
Well,
They don't
I'm
back
saying,
pay.
Yeah.
They don't back pay
Yeah.
anymore, so
They-
people
to a
don't.
point, like they can back pay to a point,
They-
but not as
well-
far as they used to. It's 90 days now and that's the max. So, yeah. Yeah.
Well, I don't know, I'm
Yeah,
just-
I know we stopped taking pendings.
I think you could.
You run a great risk financially, and you have more than a couple pendings and you're in
Mhm.
trouble
Yeah.
financially.
Right.
It's
There's
just
no
the
proof
reality.
yet. Like you don't know.
Yeah. Yeah.
It is tricky.
Well, all of that is kind of what we need to get clarified as we go forward with how all this is working and what do people know? They don't know, they don't understand.
And I'm afraid there is a big gap between what the managed care entities, how they think it's going versus the people they're supposed to be serving and how they think it's going. And when we only get feedback from one of the two entities, where we have a very, very incomplete picture of how splendid this program really is.
I don't think the Secretary of FSSA at this point thinks it's splendid. So I
And the
don't
secretary what?
thinks that the Pathways is going splendid. So he's put that public comment out there. So I caution to say, I think there's growing concerns over how Pathways is going. And it starts with the secretary and the director of Medicaid right now.
Yeah.
So.
Yeah, I was being a little facetious with this splendid comment.
I can't speak
think I
too
caught
much to the pathways piece of things, but I can tell you that we also have a quality team that we've developed for LCAR. So we've begun gathering data for that to see how LCAR is going.
Okay, we've taken our time, used our time and we haven't heard from everybody. But I knew we were going to get into a few things today, and this is us doing our due diligence as we were by statute supposed to do. So we're asking questions, and thank you for talking.
Absolutely. And if you have more questions, you know how to get a hold of us. So, yeah.
Okay, well, thank you very much.
Thank you.
We look forward to continuing to work with you. I'm going to say the advisory committee reports, I'm going to just put on hold unless there's something that somebody has to say. I'll say, we do have one project going with the Living Longer, Living Better Collaborative, and I'm doing a presentation working with some providers up in Hamilton County. See how that goes. Trying to work locally to get some solutions. So I'll be reporting on that in September. Dan is not here for the Senior Center Coalition. Hannah, can you give us some comments, and everybody just stay put. We need a few minutes with Hannah today. Thank you.
So I'm Hannah Carlock and I'm with RJL Solutions and serving as the interim CEO of the Indiana Association of Area Agencies on Aging. And thank you to those of you that were able to drive all the way down to New Albany for the House Enrolled Act ceremonial signing of 1391 with the governor. So that was July 1st. It was great to see that the governor made that a priority because he doesn't ceremonially sign every bill out there, especially on site at a location. There were roughly 60 people there, including AAA staff, FSSA staff, and Commission on Aging and Choice Board members, members of the media, legislators, AARP, and we also had some folks that utilized the Choice program that were able to be there. And 6 different media outlets did a story on it. So that was really exciting to see. House Enrolled Act 1297, which is the new yellow dot law. We are traveling around to every AAA to just discuss with them what the yellow dot law is. And if you don't know what that is a packet that FSSA is working on putting together and disseminating to BMV and AAA locations. And anybody can go and pick that packet up, and it's a sticker that you put on the rear window of your car, and that alerts first responders to know that there is pertinent medical information in the glove box, so it helps them respond quicker to your medical needs. And so we are going around and meeting at every AAA so that, one, they can build relationships with their first responders and then also educate first responders on this issue. We're also inviting legislators just so that they also can build relationships with their first responders and area agencies on aging. So we've currently been to 2 locations, 2 AAAs, and we are working through the AAA map to make sure we visit every location. Lastly, I will update, I'm sure that you guys have seen the news. President Trump signed the big, beautiful bill. Beauty, I guess, is in the eyes of the beholder because there are a lot of Medicaid cuts coming our way, which will trickle down to impact the aging population. So there will be a nearly $1 trillion in Medicaid cuts over 10 years. And of course, that's across the United States, not just Indiana. And there's some new requirements on all of that, including work requirements. And it also makes sure that people continue to get reassessed for different benefits, and states are going to have to put more skin in the game in order to continue different services and funding. And that's it. I'm happy to take any questions.
I didn't know about the yellow dot. That's really cool.
Yeah.
Thank you. Missed that.
My husband's a fire chief, so we can remember.
Yeah, but we'll be coming up for soon.
The Medicaid cuts concern me. That's why I raised the other question a little bit ago. I think eligibility is going to change. States putting more money, more skin in the game. Well, jumping up and down the state to do that. So we'll see what unfolds. Sorry, we had kind of a shortened version of what you probably have to say, but thank you very much, Hannah. Thank you, everyone who came today. We're really at such kind of a turning point where we have to find some new solutions and ways to proceed. And the more we can get here and discuss, the better. It is summer. I understand that. But we had put some things on the agenda for the September meeting, asked for, and really appreciate the divisions of health and helping us kind of move forward with this. So our next meeting will be in September, and have a good rest of the summer, everyone. With that, I'm going to adjourn the meeting.